Hi, what's going on, ladies and gentlemen? So today's video is going to be a little bit different. Today we're going to show you a day in my life in clinical. I'm going to show you around, talk a little bit about the things I do during clinical. It's totally different than what a normal school day is compared to whatever you guys saw in the first video, because this will be more in a hospital setting. But nonetheless, I still think it's important for me to discuss certain topics and cover certain areas that's important as a clinical student, because there's certain tasks that we do that I can explain, certain assignments that we do in clinical that differ than what we do normally in a lecture classroom. So I'll show you guys around and I'll see what I can show and explain to you. All right, guys, so we made it. I'm sitting in the parking lot right now. It's currently 23 degrees out. It's freezing, but we made it, so I'm grateful for that. Yeah, today is just gonna be clinical, so we'll see how that goes. You see me in scrubs with the stethoscope and everything. I'll see what I can film inside and I'll let you guys know. So I'll show you how the clinical is, the clinical setting. Day in the life of Kenneth, clinical edition. There we go. That's going to be the title of the video. Hey guys, so I just arrived at the hospital, waiting for my preceptor and clinical classmates to get here. I arrived a bit early so I could film this, but usually what happens is once I arrive on the unit or the floor, my preceptor or my professor, she gives me an assignment to do, or she gives out the assignments or the patients, and we usually have this data profile that we fill out regarding our patients. It's like this. Right now it doesn't have anything because I just printed it out, but usually write out the information regarding what we saw, like the patient diagnosis, some lab values, and how we do our assessment as nurses, our nursing assessment rather. So stuff like, are the pupils reactive? Do they have a gag reflex? Your skin turgor? That type of thing. And then usually as we fill this out throughout the day, at the end of clinical, we reconvene and discuss what we saw at clinical. Overall, what I love about clinical is that it's totally different from lecture because there's more hands-on things that you can do. You're interacting with real patients, at least where I'm at. So I get to assess vital signs, occasionally give medications under supervision of my professor or preceptor. And it's just different from lecture. You know, sitting around in a classroom all day or Zoom university, it's not the most exciting thing, just, you know, sitting all day in lecture. But clinical, it allows you to have that hands-on experience and interact with people. And that's why I love nursing and I picked it as my career. Hey, what's up guys? So we made it to lunch. We have time right now, so a little bit more time to chill and relax. Usually after clinical, usually during clinicals, your professor will give you, they should at least give you like a small break or lunch, because it's gonna be usually a long day and you wanna be able to eat or drink something at least. So stay healthy. You know, as nurses, we gotta do that because we gotta practice what we preach. But I'm just here to discuss some things that my patient had, or a few of my assessments. So for one of my patients here, I assessed her. She was doing fine. She had a chest tube, and what I like about lecture and clinical experience is for this patient, I was able to apply the stuff that I learned from lecture, let's say respiratory assessment, to the patient that I received today who had a chest tube. So I was able to observe for any titling or any kinks and assist with the patient. During the assessment, I done what my health assessment taught me, which is assess her pulses, her capillary refill, assess for any edema, auscultate lung sounds and heart sounds, all of that. And you know, you do your basic vital sign assessments, blood pressure, heart rate, pulse, respirations, etc. You're also doing the neurological assessment. So you're assessing their mental status. Are they alert and oriented? How's their speech? You're assessing the range of motion, you're implementing all these skill sets that you learn from your lecture and implementing it into towards the clinical setting. So in clinical, you're applying those skill sets physically towards the patients. You don't really notice it at first, but over time, as you get used to it, you're gonna progress and get more used to it, and you'll be doing it like you'll be reading it like the back of your hand. You'll get used to it. You're also assessing if the patient is at risk for falls, any ulcer assessments. You're assessing for any ulcers, if they're bedbound, or even in general, you're assessing for ulcers. And that's about it for the patient database. Also, usually about in the middle of the semester, I guess, or in the middle of the clinical, after 1 to 2 clinicals, typically your professor will make you fill out a concept map that just essentially lists out the things that you learned and the things that regarding your patient, and you implement it into this map, and you do a nursing diagnosis about your patient. I'll show more about it when I get home. I don't have it with me right now, but it's at home, so if I have more time, I'll show it to you guys. Made it back home, and I am going to show you the patient profile template and the concept map template now. So right here, this is the patient profile template. As a nursing student, you receive this sheet and you fill it out as you're assessing your patient. A lot of this information, as you can see here, the admission profile, they have it in their charting. So you can fill it out. You can ask the nurse, your preceptor, for the chart, and you generally fill out this information that they already have. The medications too, and any diagnostic tests. The part that I feel that is very crucial as a nursing student, because you're learning as well, is the assessment part of this patient profile template. Essentially what you do here, as you can see, you see the allergies, pain, when was the last time the pain medication was given, the diet, that type of thing. You want to be able to assess your patient, communicate with them if they're able to communicate, and assess their general status and well-being, and see if you're able to derive that information and input it here. So for example, let's see circle those problems that apply. When you're assessing your patients, you want to assess them perform a head-to-toe assessment and note any issues or problems that they may have. So for constipation, you might want to ask, when was the last time you had a bowel movement? And if they said it was 2 days ago, that's something you want to keep in mind of as a nursing student. Activity, that's also something that you can assess as a nursing student. Their ability to walk, any types of activities, use of any assistive devices. These are things that you will need to keep in mind of as a nurse, because when you're taking care of a patient, you want to be aware of their limitations. You also want to be aware of any conditions that they may have. And as we see here, you have the physical assessment data. You have the blood pressure, the pulse, respirations, temperature, height, weight, BMI. These are things that, generally speaking, as a nursing student, you'll perform. And then, of course, you have the review of systems, their neurological, their mental status. That's stuff that you also perform in the beginning when you're assessing your patient. In a sense, a neurovascular assessment. You check if they're alert and oriented, can they speak, the range of motions, are the pupils equal and reactive to light. You also have the musculoskeletal system. You assess if they're able to move, or do they have any fractures, do they have any casts, or any of that. The cardiovascular, again, you're taking their pulse, you're assessing their heart rate, you're asking them if they're experiencing any chest pain. Respiratory system, you're counting the respirations, you're assessing if they're able to breathe properly, is there pursed lip breathing, what are the breath sounds, you're auscultating as well. And the GI system, you're auscultating for bowel sounds, you're observing if they're abdomen is distended or they bloated. And if they have an ostomy, you're describing their stools. You also have their skin and wounds. You're assessing their skin is very crucial because your skin, as we know, is their first line of defense. And if it gets penetrated, it may lead to other complications. And you have the eyes, ears, nose, and throat, and the psychosocial and cultural assessment. Generally speaking, as nurses, we tend to overlook their psychosocial and cultural assessment, but I feel that it's very important to keep in mind because their cultural assessment and their psychosocial assessment is stuff that's very crucial to their mental health and their general well-being as well. And of course, you have the risk for decubitus ulcer assessment rating. This is important too because if your patient is not able to move or if they're bedbound, you want to assess for any pressure injuries, any pressure ulcers that may develop over time. And then you have their Morse fall scale. Here you note that if they're at risk for any falls. And here you just fill it out. You're assessing if they have a history of falling, you circle yes, you put 25. And if they have more than 2 diagnoses in their chart, pick yes, etc. And then as we see here, once you fill it out, if it's less than 25, it's low risk. 25 to 45, it's moderate risk. Greater than 45, it's a high risk. This is what it looks like when the patient profile database is completed. This is for one of my patients. I left out the date of care, their initials, and the admission state for privacy reasons. But this is just an example. We see the reason for hospitalization for this patient was an intestinal obstruction and hernia. And I listed some of the past medical history, the medical diagnosis that they had. This patient had diabetes, obstructive sleep apnea, osteoarthritis, pulmonary embolism, acute respiratory failure with hypoxia. So as we can see, this patient that I had a lot of medical history, and this stuff is important because we want to be able to apply this into our care of the patient. We also have to note any surgical procedures that this patient had. This patient had a C-section, a ventral hernia repair, and the presence of an IVC filter and a total knee replacement. Again, here are some lab values for this patient during their care. You had the norms, the on admission, and the current values. This is the stuff that I filled out in the chart. I filled it out to the best of my ability. And these are just some things you can find in the chart. You could ask the nurse or your preceptor. Some diagnostic tests that this patient had. As you could see, small bowel obstructions, air accumulating in the bowels, there's distension. Here are just a list of medications that this patient was receiving. The allergies, this patient was allergic to penicillin. When was the last time? There were no orders. Again, a lot of this information was from the charts that the nurse or my preceptor already had prior to going in. So I just copied some of the information there. The part that I stress was the assessment part, because this is where it's more dependent on you as a nursing student and as a nurse. These are things that when you become a nurse that you have to pick up on. No one is really going to give you the information. It's not like a chart where someone just hands it to you, because you're going to be performing your own assessment for your patient. So I know for this patient, they had an issue with their bowel and an intestinal obstruction. That was in the past medical history. And on top of that, I asked the patient, are you experiencing any issues, etc.? And she verbalized, she told me that she had issues with her bowel and she felt very bloated. Hence, I wrote bowel and intestinal obstructions that may apply to this scenario. The physical assessment, this is the vital signs that you take. Again, you keep doing it over time, you get used to it. Her blood pressure was 107/53. Her pulse, as we could see, was very high. Normally, pulse is 60 to 100 beats per minute. This patient was 140 beats per minute. And that was something to note,
because as we can connect this high pulse with the intestinal obstruction, we're able to connect the two dots and see, oh, is the heart compensating for another issue, which is that which could be a potential issue, which was the intestinal obstruction. The patient was alert and oriented. Her speech was clear, and her range of motion was present. That stuff we weren't too worried about, but we were visibly able to see that she was able to move. She was able to communicate with us. Her musculoskeletal, again, we asked her, she has a history of osteoarthritis. And again, during the assessment phase, when we do perform the head-to-toe assessment, we note any abnormalities that the patient may have. So when I was assessing this patient, I noticed that she had a little bit of edema on her legs. So I just made a note of that right here. Her pulses, I took a brachial pulse. Her capillary refill was less than 3 seconds, so that's good. She had a little bit of edema. Again, it was non-pitting. There were no neck distensions. She had regular S1 and S2. She did say she had some chest pain, but again, I tied it in connection with her distended abdomen. In my mind, I was just trying to connect the two dots. Her breath sounds, they were normal, no adventitious breath sounds, no use of accessory muscles, no cyanosis. She had no cough, no history of smoking. Oxygen saturation was 95%. She was not on oxygen. She was not on oxygen humidification. She did have a nasal cannula on her. It was 3 liters. And her breath sounds, there was some wheezing. Again, this goes back to the health assessment where you're auscultating her, you're listening, auscultating breath sounds and trying to listen to see if there's any abnormalities. Abdomen was slightly distended, faint bowel sounds. There was no NG tube, no ostomy. Her skin was brown and normal, no wounds, edges approximated, no wounds. Any dressings that she had, it was dry and intact. And her decubitus ulcer assessment rating was a 17. This was her psychosocial, her religious. She was Hindu, she was married, and she's retired. As I mentioned, this was 17. So her mobility was very limited. We saw her BMI was slightly high, so it was she was obese, but hence she scored a 2. She's rarely moist. She's able to get up occasionally. She's not sitting in moisture or urine, so she was rarely moist. Her activity, she was bed rest, but occasionally she was able to get up sometimes, or the nurse was able to, assist her in turning her. Friction, there may have been potential problems. She moves feebly or requires assistance. She definitely required assistance. Her nutritional status was excellent. She was able to eat. She didn't complain about that. And sensory perception, there was no impairment, so she scored a 17. Her risk for falls, she never had a fall in the past, so that was 0. She did have more than 2 diagnoses in her chart, so she scored a 15. Her ambulatory aid, she uses a walker, so she got a 15. She did have intravenous therapy, so she got a 20 on that. She was bed rest, so 0. And she's oriented to her own ability. So as we see, she was a high risk for falls patient, so that's something that we noted. So this is the concept map template. This is what we use to fill out the concept map with, obviously, but what we just filled out, what you saw before, was the patient database, and we're going to use that information and input it here. So it looks more neat, and we're able to create a plan of care for our patients. So without further ado, let's start. This is what we start off with, the centerpiece. We have the reason for needing the healthcare, the medical diagnosis history. This is what we filled out, what we had in the patient database before. And then we also have the key assessments to be performed on this patients. And you list out any key problems supporting data assessments, any of that stuff that we got from assessing our patient. Now, here are the problems that we have. The nursing diagnosis. The nursing diagnosis, we have to write it in a certain format. And it's the whatever the issue is related to as evidenced by format, which I will show you later as well. And you have some nursing interventions that you have, the rationale on why you're implementing those interventions, and how the patient responded to those interventions. This is important because we want to evaluate if our plan of care was effective, if our interventions were effective, and if there's anything that we can do to assist our patients. And you also have the family discharge, the patient family teaching and discharge planning, which is important as well because we want to ensure that our patients are receiving effective care when they're at home and they have a plan of how they're going to take care of themselves upon discharge. Again, the evaluation is we're seeing if any of our interventions were effective. If they were effective, good. If they were not effective, why not? Any future things that we need to do or plans of improvement. And again, you have your references where you cite your sources that you used. So generally speaking, you fill one for each, depending on how many your preceptor or professor wants, and you just keep going, just like that. And here is the concept map that's completed. As we can see, I filled out everything from the patient profile database and I put it into the concept map. So let's get started. As we can see, the reason for seeking healthcare and medical surgical diagnosis was intestinal obstruction, hernia, diabetes, osteoarthritis, and pulmonary embolism. These were the issues that the patient was facing based off of her past medical history. And these are the key assessments that I performed for the patient. So the key problems here, as we can see, I just listed any potential problems that the patient may face during my plan of care for this patient. For the first one was acute pain, and the supporting data and assessments were the distended abdomen, the faint bowel sounds, and the patient verbally told us that she was experiencing a pain on a scale of 6 out of 10. Key number 2, we see imbalanced nutrition. The patient has diabetes, she has an elevated blood sugar, and she is obese. So these three supporting data and assessments connect with the imbalanced nutrition issue that she has. The third problem that she faces is anxiety. The patient was admitted for intestinal obstruction. The patient is away from family members, and the patient's heart rate is 140 beats per minute, which supports the potential anxiety problem. And key problem number 4 is the risk for ineffective airway clearance. As we saw, she had a history of obstructive sleep apnea, and she has a history of pulmonary embolism and acute respiratory failure with hypoxia. So this is the first part of our concept map that we fill out. Generally, I fill out the center first, and I use the center to build upon the key problems. So as we see here, the nursing diagnosis, if you recall, I said that it had to be in a certain format, in a nursing diagnosis format. So we had to write it in a certain way. So the way we wrote it is acute pain related to small bowel obstruction as evidenced by distended abdomen. There we go, making a correction. As evidenced by distended abdomen. And our goal and outcome for this problem is that we want the patient to have her pain levels reduced to a level below 4 out of 10. So how are we going to achieve this goal or outcome? We're going to do this via nursing interventions. And as we see here, these are some interventions that came up to my mind on how we're going to assist the patient in reducing her pain levels. The first intervention was we're going to administer pain medications, and we have the rationale here. The rationale just explains why we're doing this intervention. And then we have the patient response to the intervention on essentially describing what the outcome was after we implemented this intervention. Did it help? As we see here, there were no medications ordered for the patient, but we notified the provider of her pain and will continue to monitor the patient. So we initially planned to administer pain medications, but there were none ordered, so we had to consult with the provider. And essentially, we just kept doing this. We kept doing various nursing interventions that we think are going to help with the patient in dealing with her pain. And as we see, we have multiple nursing interventions here, and we have the rationale and the patient response to these interventions. And essentially, it's the same format throughout this concept map that we're doing. Now, onto the patient family teaching. This part is somewhat different than what our nursing intervention rationale and patient response to the intervention is. Here, we describe how we plan to teach the patient and their family members upon discharge, because we want to ensure that they're able to care for themselves at home and that they have a plan on how they're going to care for themselves upon discharge. So for this patient, I wrote, I will educate the patient's family members the importance of assisting the patients with certain activities of daily living, such as walking. This is because the patient uses a walker, hence it is important for the family to watch and assist the patient in order to prevent any falls or injuries. This connects to the idea of reducing her pain levels, because essentially for the patient, we want her to feel comfortable. We don't want her to aggravate any injuries that she has. So we want to educate them that before the patient gets up, find assistance or communicate with the family members. And the evaluation, we're evaluating whether all of these interventions were effective and whether our teaching was effective. So we see the interventions were successful in helping the patient reduce her pain levels, because after the interventions were applied, the patient acknowledged that her pain level was 3 out of 10 compared to 6 out of 10 prior to the interventions. Therefore, it is important to incorporate both pharmacological and non-pharmacological measures to reduce pain, as both means ensure the patient is comfortable. So as you can see, I wrote out the results of after applying all these interventions to the patients and whether our goal was met or not, which it was met, because after applying those interventions, we asked the patient again how she felt, and she said she felt better. Her pain was lower compared to when we did not apply these interventions. And again, the other problems that we have, we did the same thing where we create a nursing diagnosis. As we see for number 2, it's imbalanced nutrition related to deficient knowledge, as evidenced by BMI of 44.9. We have to do it in that certain format. It's just the way we do nursing diagnosis. And again, we have a goal and outcome, and we have the nursing interventions to implement so that we can reach our goal or outcome. And we just keep doing this throughout the concept map until we meet our goals, until we do however many our preceptor or instructor wants us to do. So if you want, you could feel free to look at it right here. Just show you guys some of the things that I write. Again, feel free to pause the video. If you guys want some ideas and stuff, you could just look at it. Oh, one more thing. The references, those are important too. Depending on who your professor is, they may require you to write it in a certain format. My professor wanted us to write it in APA format, so I just made it into APA format. I got the information from Nurse Labs, and I plug it into like an APA citation machine, and it cites it for you, just like that. And again, here's another one, the anxiety. As we can see, it's the same thing, same format. We want to keep the format consistent so that it's effective and that we know what we're writing out, and it's more organized in a sense when we're writing a care plan for our patient. And there you go, ladies and gentlemen. That's the concept map. My professor just wanted us to write 3 key problems, do the chart for 3, but she wanted us to have 4 boxes, but just do the charts for 3 of them. And here it is. And I hope you guys enjoyed the video. I hope you guys learned something from it. And this is pretty much what you do in clinical, not the entire thing, but you you have your clinical experience, which is the hands-on part of nursing, where you're dealing with patients, you're assisting them physically, you're applying those hands-on skills that you have. And then you also have the portion where you're essentially coming up with a care plan, writing things out on a concept map, and you're trying to connect the things that you learned from lecture and implement it into the clinical setting. And this is just showing you what you do. So we went from clinical with hands-on experience onto the patient profile database where we're recording our observations and assessments. And now we have the concept map, which puts everything together and allows us to identify how we're going to assist our patients and create a plan of care for them. And I hope you guys enjoyed the video and have a nice day.